especially amongst the Catholic-based groups, and I have said that running a health institution requires people who can manage it as a business and not only manage it as a center of faith, and that it doesn't have to be Mother Superior. They have sometimes taken fault with that, but I really mean it. That's just like we waste the surgeon to be a medical superintendent when he can't manage. We cannot waste Mother Superior or the priest to be the one managing these things. Let's be frank about this thing and say that there is an efficiency model that can bring in not less than the 40 or 60% that we're wasting at the moment. And that is money that we already have. And I would say that living here, that is a model that we ought to all be starting looking at. How do we use the pennies that we have, if they are that scarce, better? The second model is the PPP model. In the last 5 years, I've been assigned by the World Bank Group, IFC and the World Bank, to work with African governments and entrepreneurs to create an enabling environment for more investment in health and bring in the non-state actors to be on the same table, round and equal with the government. And I have worked across the continent on this. And I've had some very, very interesting experiences. One is that when we start looking at non-state actors, which we look at both the faith-based, not-for-profit, and the for-profit ones, there's a tendency for the faith-based one to say we are different, we are not like them. And yet, for the government, they're looking at all of you as non-state actors. Two, there's been a tendency from the faith-based to tell me that we are already talking with the government, we don't need better dialogue. But then when I come here, the first thing that I'm hearing, being challenged by my sister in WHO, that nobody is recognizing us. So you have to be truthful to yourselves. The very, very fact that you've had a long history of engagement with government and signed these MOUs doesn't mean that you have a productive relationship. And when I read the MOUs that you signed all over the continent, they're probably some of the most useless documents that anybody who is thinking of contracting seriously in health would do. But you're very happy with them. Maybe it is a matter of faith. But these things are now legal, they are contractual. And we have to change the contracting completely and redo the PPP arrangements that we have. Because you are private sector, they are public sector, and you need a relationship. That means that everybody keeps to their own words. That will mean that rather than a government coming in and finding that you are in Karamoja or in Turkana, like Dr. Dogo has just been telling me, and finding that you are the only one providing care there. So their solution is that next year we will build a hospital next to yours. The solution should be, you are doing that so well, why don't we give you more money to do more and do better? If your MOUs cannot do that, then forget about them. You're wasting everybody's time. And yet this is exactly what's happening. So you end up then with two institutions, one faith-based struggling, and a government one that is built next door, a beautiful building with no staff and no services. And this is the picture. If you went and took on the satellite picture in Africa, you will see this all over the place. And you don't have to do it at night, at daytime, you will see it all over the place. So that model is a model that has to be expanded and be done better. The fourth model is the health insurance model. Africa is into the decade of health insurance. And we're all struggling, every country, to put in place some form of social insurance. Yes, there are nasty political things, but the discussion is going on. And they're beginning to expand. It's no longer just Rwanda or Ghana. Kenya is expanding, and in fact, in probably another year, we'll have more than 60% of this population in Kenya here covered by NHIF. And it's happening in Tanzania too, where they have started. It's happening in every country where we are working in. And I know it's Nigeria and everything. But then, you seem to avoid the discussion in this area. You are not on it. So you are happy sometimes because you are not for profit, When people say there is free maternity services, you say that's the best thing, even if it does not deliver anything. You saw Dr. Kolongo's slide, free maternity services in public institutions. That doesn't include you. Why are you not in that? It's because simple. The government of Kenya is rewarding every public facility for every delivery done, but not the faith-based one for every delivery done. Now, you don't have to go to Harvard Medical School to see that there's something very wrong here. And why are we allowing it to happen? Where are we in the dialogue? And why are we thinking of a model that says that the woman has a right to deliver where she wants to? If this country wants to give every woman free delivery, then pay for every place where this woman can deliver safely. But fix the cost and do it. That's a decision, and we've met with the Ministry of Health, and I hope that they're going to be doing that in the next few months for that to happen. That's a model that we have to start looking at when we start looking at health insurance and how it helps us. Without health insurance, all these non-state and even state models that we have in Africa are all going to be where they are. They will not grow. The fourth model is, for want of a better word, I'll call it the external, or not external, but donor-supported model. That was the advent of the faith-based institutions in this continent, where in the days when people used to build churches in Europe and America, there used to be quite a bit of collection and money that came into Africa. But now if you go to those churches, you will find that they don't fill up anymore. And when they do, they're people my age or older. So the well is drying up. But then in this model of donor, we still have in Africa tried to see donor as being somebody who is outside of the continent. Philanthropy is color-blind. And we are now in Africa seeing people who are as rich as everybody else in the world. To the point that when we challenged the Nigerian ones in the work that we're doing in Nigeria, Daliko Angote gave $20 million on the go. Here is a check for the private non-state actors to do their thing. And Daliko Angote is not unique. They're there. Some of them come to church. They may not believe in the preaching, but they do. But then we are only going to them with this small little bag for them to put in 100 shillings, 200 shillings, and we are not meeting them in their offices to ask them that there is a bigger mission where your money can go. And we are burying them now in Africa here, that first generation of rich people. And a lot of their money is in Swiss banks. And none of you is talking to them to say that that money can actually be used in a foundation here. And those foundations can be faith-based and can be managed better. Those four models are models that I want you to keep in mind, because what you've worked on so far, where somebody comes from somewhere to give you money, that one is gone. Now moving from that, we start asking ourselves, where does the bigger money that comes from the World Bank and other bilaterals sit in? For those of you who are in maternal and child health, you will recall that since 2000, the year 2000, there has been a struggle to create financing models or financing resources for maternal and child health. A lot of these globally have come in through special initiatives, like the HIV/AIDS initiative that we have in the World Bank. We now have the Global Fund, and we have several funds. And there have been a lot of discussions, Miriam, you are in UNFPA then, on whether there should be a special initiative or a funding bank for mother and child, because UHC for us in Africa starts with the mother and child. If they are not in it, then you don't even discuss it. And over nearly 15 years I've been involved in that, until fairly recently that came up this issue of the Global Financing Facility, GFF. How many of you have heard about this? How many of you have participated in asking where it's coming from and where it is going and how it helps the faith-based groups? This is why it started. That yes, we have had some momentum through the MDGs to 2015, and it has made some difference. There were people at the beginning who were very, very skeptical and saying, we'll never reach those goals, so why try it? But there are also many people who say, if you don't try, you'll not go anywhere. And I think that we have gotten somewhere. But then, the agenda, as we are in 2015 now, just like we were in the year 2000 for Health for All, is unfinished. And it is unfinished for reasons that we are showing you there on the slide. The gaps are still there. The sustainability of the progress cannot be guaranteed. There's still these inefficiencies that we talk about. And there is, for our countries, the whole issue of getting the right data, the baseline data that comes out of registration and so on. And the big issue here is not so much how much comes from outside, but how much domestic resource is there and how much can we raise for health. This is coming in at a time when Africa has never been more endowed with in the extractive industry area. Fine, the oil prices are down, but there's all other minerals that are offered. And in fact, our figures are worse in health for countries that are more endowed with these resources. But then when we talk to the companies and the people who are there, what do? We go for the small little things with them. We don't go to the big companies and say, can you put big money and work with the faith-based in this particular area? No, small little things. You go to Shell, and I don't know whether you have met with Shell as faith-based organizations and asked for something that's really big and transformative, rather than getting the few pennies that people get from there. That's not happening. The GFF then is therefore part of a broader global effort of financing for development. And this is an effort that we must all be in, because we in the health sector have the habit of thinking that we are so different and money will just come. We are part of development. And that's why we do not even participate in the discussion in the ministries of finance, because we think this is not where we go to be. We are part of that. So that then is where this GFF issues come from. The ultimate goal of this is already written down. And these figures that we want to reduce will not happen until this continent wakes up and makes a movement, and until the parts of this continent where you provide care get to spend these resources efficiently. And I repeat that, until the parts of the continent and the populations that you serve are reached, it is not going to be possible for us to do this. I make this as a statement to confirm to you that you are much more important to this global effort than the global effort is to you. And it is up to you to make sure that you stand up, you are not threatened by anybody, and you are there and say so. That if we don't give this service, because we are the only ones who have done it for those years, we can scale it up quickly, it is not going to happen. Then we are going to be missing on the boat. The key focus areas are the ones that you have there. Mobilize and channel additional international and domestic resources required for scaling up. Because what you're dealing with is not just sustaining what you have, but scaling up. Then long-term sustainability of domestic financing. Extremely important for us to be able to move forward. And then the civil registration. The countries in the world that have some of the best civil registration, I get an example of the Scandinavian countries, actually started it from the church basis. The mobilizer for registration in this continent can never be better than the church basis for it. So when we start talking civil registration, please do not feel left out on that, because you are an important part and can play even more that's out there. The commitments to date, that's where it is. And it may look a lot of money in those figures, but in 5 years' time, this money will be gone, and you will not be part of it unless you insist that you are part of it. Because it's very, very easy to spend this money without it reaching the people that you must reach and that only you can serve. Now, what is the operating model that the GFS is putting on the table? That is essentially the driver of the overall GFF approach. And you can see that there is SMART. It has to be sustainable, and it has to be scaled up. And that smartness is key to moving forward from where you and everybody is right now. That scaling up is an absolute, because we are all doing far too little at a time when we need more, and sustainability is important. Because unless you have predictable financing, you cannot scale up, and sustainability will be a problem. The two graphs there gives you a sense of where we are right now in terms of the way we work in this sector. With the government putting in some, donors putting in some, the private sector, everybody putting in that, but we are not covering that circle universally. And this is not a money issue, it's a model issue on how we can do differently. The Minister of Health told you in the morning that in Kenya, the donor funding, 65% of it is outside of the budget. So if you ask them what it is doing, they will not tell you in any detail. Nobody's saying it comes to the budget, but everybody agrees that the planning ought to be done together so that we know where that money goes. And this is what GFF must do and do differently. The rigorous data basis has to be there. There's too many things that we do in faith, but we do not monitor. So the hope is that with vital registration improving, we shall have a population basis for what we do. I'll give you an example, and let me give you an example of what the Minister of Health has presented here this morning. Free maternity care has come in. The number of deliveries in institutions has gone up by X percentage. Conclusion, if it continues this way, maternal mortality will go down. Does it make sense? Will it necessarily go down? But that's a good political statement, but not a good technical statement. Because you want to ask, who are these people who are coming in? Where were they delivering before? Were they going to faith-based, but they're now coming to the government ones? So they're already delivering in a place where they would be safe, but they have shifted. Are we really going down to get the people who did not have antenatal care and so on? And then we're measuring people who deliver here. But we know that delivery alone is not enough. There's antenatal care and postnatal care. Did they have antenatal care? Will they have postnatal care? Data has to be in there for us to be able to move this to the next level, because we are scientists above everything else. Now, scaling becomes an important for the 2030 targets. And if we are not scaling, then it won't happen. And I want to put it to you that you should insist that that scaling is not just done in terms of the national data, but done also in the desegregated data. If the faith-based non-state actors in Africa are not scaling up, then that scaling up is not really happening. Because public institutions on their own cannot handle the workload that is needed for this to happen. We know it. And definitely, even if they were to do it, they cannot do it within a year or 2 years, because they don't have all those facilities to set up. but your facilities, some of which are working at 20% bed occupancy, and you have staff there, it will be much quicker to get them filled up with people who need this care because somebody is helping pay for that than building new ones and moving forward in that area. So scaling up has to be seen in that particular context. Now, the resources from the World Bank, where are they coming from? Is IDA, because we're focusing on the 63 countries of lowest income and with all the problems that are there. Nearly each one of them is in Africa. Nearly each one of them is one of your countries. So this is where we are in terms of that money. There's trust fund money, but there is also money that is coming in. Unfortunately, the World Bank, just like WHO, comes in through government. And you will ask, why don't you come through us? But you are the ones who have created this international infrastructure. If we come in through government, do we reach you? Are you part of the health dialogue in your own countries? Is it enough because you signed an MOU that when this thing comes, that MOU will be remembered? This is why we've been struggling to restructure this sector so that a minister of health in a country does not see himself as a minister of the Ministry of Health, but a minister for the sector. And that sector, when you look at it in terms of who's spending money there, who's being treated, who has a facility, that sector is mixed sector of state and non-state. So as a minister, that is what you do. In the last WHO regional meeting, or one of the previous ones that I had attended, I had asked my fellow senior ministers for health in Africa, which one of you feels that you're minister for both the public and the private sector? And only 3 put up their hands. That the non-state actors are not under them. So when the World Bank or WHO come to talk to us because those are the people. It is not them or us if they're providing the data. But when they give the data of health outcome in the country, 55% of which come from non-state actors, they very readily take the whole of that data and say, this is what we have done. This is where the dialogue has to change, and this is where you have to come in and come in strongly. Now, scaling up means also efficiency. Pooling and sharing. There's too much overlapping in the things that we do. It's not just overlapping between public and private. It's not just overlapping between donors, but it's also overlapping between the different faith organizations within ACHAP. So this one is Presbyterian, and this one is Anglican, but they are next to each other, and they are fighting for the same patient group. Now, God is one. God is one. And if this same God is watching what you are doing, then I'm sure that is telling you that surely, even within us, we can do better in terms of pooling our resources and moving things forward together. This is exactly what you have done very, very well in this region with meds, serving all those ones there. And we can do it also in the area of facilities. We can do it also in the area of employing some staff. Give you an example, and I gave it yesterday. Consultants working in your hospital. If the Anglican church next door has a surgeon, surely that surgeon can also operate in the Presbyterian hospital over there. Because you can't keep a surgeon busy in just one place. And you can share the cost of that surgeon. So we have this FPO surgeon who's serving this region, who's paid by all of them, so that we can all afford this person, rather than each one of us working towards that. Then there is also the issue of new partners. And those new partners is a challenge that has to come through all these models that I started with. And those new partners must be partners who are interested in the performance that is done. And for us in Africa, I believe that the most important new partner must be the Africans themselves. The Africans who have made it through hook or crook They have the money. We've got to bring them to repent and give some of this money. So, where is that effort? I want to see that effort coming out of there, that we are reaching out to the 20 richest Africans to work with the church to make a difference for women and children. If you need help in that, I'm willing to give you help on that. And my institution will be giving you help in that, because we know them, we know where they are, and they actually mean very, very well. And they'll feel gratified that somebody is trying to recognize them to use that. Those new resources must also come in the area of the kind of national mobilization that's there. There's been a lot of talk on taxation. New forms of taxation. You heard about the airline tax, where we're saying every flight to Africa, there must be some few cents that comes to the health sector. We've talked about the money transfer tax, because we have a lot of money from the diaspora coming in, that if everything, that the Western Union and everybody, there was 1 cent out of that, there would be enough money in it. Then there's also been the sin tax from alcohol and tobacco and everywhere else. Do you support that or do you not support that? Can it be driven to help this continent move forward? Now, sustainability is going to be the key. And I see sustainability as being more locally grown resources and more local efficiencies. 2 things that you must do well in each and every model that you want to work on. And that means too, that as the resources go up, we have to start asking ourselves, what is the cost of healthcare? I've just been doing some analysis here in Kenya, and we have found that Nairobi is one of the most expensive cities in terms of health. The cost of healthcare in this continent, everything given, is amazing. It is so expensive that health workers themselves cannot afford to be treated in the facilities in which they work. You look at it from the inputs that we have in there, whether it is medicine and so on, which we keep taxing even for essential medicines and putting all the VAT in it. You look at it in terms of the salaries that are in there at certain levels, and you look at it in infrastructure. Right now, it is cheaper for any African to put his whole family on Kenya Airways, plus their grandmother who has cancer or whatever it is, and go to India for 1 month and come back with full treatment, than it is to get that person to be treated in Nairobi or in Dubai. There must be something wrong with the model of healthcare that we have here. And the model of the healthcare that we've had here is a model that serves a few people who do not want to be treated here. It's never been a model for the people who want to get care here. To the extent that now, the healthcare is driving the airline industry in Africa. There's been a lot of growth in the east-west flights. Kenya Airways, Ethiopian Airlines, Turkish Airlines coming on board, Emirates, Qatar, they're coming in. 1/4 to 1/3 of their passengers are sick Africans who are going into the Middle East and to India for treatment. Nigeria, my favorite country, last year, you sent 30,000 Nigerians for treatment in India at a cost of $1 billion. East Africa, you send people to India, smaller numbers, and that cost to $1 billion. And you're asking that we do not have money to take care of our own people. Sorry, my pointer has gone down here and the batteries are off, so you can switch there the next one for me. So the thing that I would like to work with you on is in this area. Sustainable incentives for domestic resource mobilization. Is there something that we can do together with the faith-based, with the World Bank Group, to start looking at what we can do locally in terms of the formal side and providing the capacity here for you to do it on the informal side for us to do that. But beyond that, this is the way we should do. Let's look at ourselves as part of the countries that we are in and ask what kind of taxation, if at all, will help us raise more money. Let us start looking at philanthropy as colorblind and let it start from the base. Let us start looking at health insurance beyond community-based health insurance, where you have done a lot of work, but where, unfortunately, sustainability is a problem. Let's be leading in the dialogue and crying for social health insurance to run. Inefficient it might be, but let's deal with those inefficiencies. And let us look at the business models. And one that I'm thinking of. Could the faith-based institutions, with all the facilities that they have, form themselves into a social franchise? Let me ask Kenyans. A few years ago, when NHIF wanted to contract with institutions that could provide multiple centers of care, they ended up with Meridian and another one that didn't have the facilities that you had. Suppose you went together as a franchise and say, we can actually provide this. Those billions would have come to your pockets and you'll be the ones running it. But you're too divided and probably too proud to think of that. And I'm talking of social franchising because I believe that even when you're not for profit, you're definitely not for loss. And if the only reason why you're in this thing is for loss, then you just won't sustain it. Some of the most viable health facilities in this continent that we go to, even in this city, the Aga Khans, the Nairobis, the MP Shahs are all not for profit. But they know that they can make money from somebody who has more money and be a Robin Hood to spend it on people who have less money. So, being Robin Hood is Christian. And we have to start asking ourselves why we cannot go there, because only in doing so shall we come up with the smart financing which we need, which has four things. One, it must be predictable. Two, it must be extremely efficient. Three, it must be scalable and sustainable. The World Bank Group, myself in particular, will be more than happy to work with the faith-based groups in Africa to make this happen. Thank you.
I wish we had more time. Because of the limitation of time, the subject here, are there quick two questions for Professor Rogo as we prepare for the next presenter? I've seen two hands there. Our sister there. Please speak to the mic and ask your question.
Thank you for a very interesting topic on healthcare financing. I'm just as narrator from Kenya and speaking about the experience of the national healthcare universal coverage with a 10-year history of from 2004. I remember when the National Health Insurance Fund came seeking to contract faith-based hospitals with three levels of contract, one for the private hospitals, one for the FBOs, and one for the government facilities. The drive really for that was like almost one-sided dialogue with the NHIF preparing contracts ahead of time without any discussion at all, and without any bearing the costs which are being incurred to the health sector, and driving that in a way that is completely devoid of dialogue. And so my comment is really, this is timely dialogue to really engage in what does it cost, what is available to reimburse, mothers when they come and deliver in FBOs, because it can be done, but the dialogue is not working properly. That's the moment.
Any other question?
Hello, thank you for your presentation. I was very intrigued that you talked about the GFF. We know that there was just a meeting in Kenya a few weeks ago, and we know there's upcoming meetings in Ethiopia and DRC. But as far as we know, no faith-based organizations have been invited to participate in those meetings. And I'm just curious if you have any role in ensuring that FBOs will be included. Thank you.
Thank you very much, Brianna Sitile from Zimbabwe. I think this has been an eye-opener, and we feel like we're fellows which have been put away to realize that as faith-based organization, we are still naked in terms of getting where we're supposed to get. But I would like to propose maybe to say that I think if we have people like yourself as advisors to the FDO or to the CHARS, it will help us a lot to move forward, because there's so much information which we don't have, which you can actually build on. And for me, the presentation really opened a lot of avenues and new ideas to deal with. However, I also want to go back to our boards, management boards. Some of them are more faith-based or religious leaders, and sometimes when you come up strongly, they might think we're going against the doctrines, and what we need maybe is to have the capacity to look into the governance of a faith-based organization and building our capacity to actually operate at a different level. Thank you.
There's the last hand here from, wow, too many hands now. One here.
Thank you. My name is Jonathan Kiliko from NETS, and mine is to thank you, Prof, for the nice presentation. And I do believe when passion works together with skill, you get masterpiece. So with this wealth of experience and also interacting with the public sector, how can you work together with this faith? It's a challenge you bring to us, that you can hold the hands of these ACHAP members to realize more impact in Africa.
Very quick, the last two hands there, seen. Yes, please. Yeah.
Well, thank you so much for frankly talking about the issues that we really, in our hearts, know but don't want to talk about, i.e. MOUs. The question is, how can we practically interface with this organization?
I think you can respond to this.
One more.
Thank you, Prof. My name is Pascal Manyoru, NETS as well. You mentioned something about the faith-based actually working closely with the government and not having what we call an agreed deal in some cases using the MOUs. And that also takes reference to what the chair of ACHAP, the challenge she posed to her excellence there. You know, it is very difficult sometimes for the faith-based to engage the government of different countries, because, as we mentioned earlier on, when results are positive and statistics show that we have a lot to showcase, then the faith-based brought in. But otherwise, we are put up with the equation. You people who, yourself, for example, working close with the IMF and World Bank, you have a lot of muscle, and the government is very willing to listen to you. My challenge probably would be, how you can help us, is when engaging the various governments, why don't you challenge them and say, to what extent are you engaging the faith-based? We see, for example, in Kenya, we talk of between 40 and 45% of the health care provided by the faith-based. Now, when you are actually discussing the government, because it's worried about the government interactions, why don't you bring in aspect of saying, asking the questions, how much are you engaging the faith-based? Why don't you actually engage the faith-based? Make sure that a facility in Uganda exists in faith-based, is not put together, close to another one built by the CDF budget just because of political thing. So we also think that you can go a bit more than you're doing at the moment by actually chatting with these governments and ensuring that they work closely with faith-based in policy and many other areas of operations.
Okay, just respond to those.
Thank you very much. I do have some documents here that I carried with me as a sample of what information we have in the country. We have the Red Book of the Business of Health in Africa. I know the moment one business comes in, you people think that somebody is making money and going anywhere with it. No. When you're running an institution, it is a business. You have a book, balance your books, see what's happening with non-state actors. Two, you have this blue book called Healthy Partnerships. It looks at all the 50-something countries in Africa and gives you an idea of how much governments are engaging with non-state actors. It is horrible. And a lot of these are countries that have signed MOUs with you and you think that you're doing well. There is money there that you could be using, but it is not coming to you. Somebody asked about NHIF. We've done a lot of work in this country on NHIF and the dialogue process that's there. There's a whole document here that would benefit you called the first ever audit of NHIF and setting up the dialogue processes that are in there. There's a lot. Some vendor will tell you how much work we have done in this country to try and bring this dialogue process working. PPD, public-private dialogue, is a key area for us to be able to move forward. So we can take that one offline and I'll be able to give you a sense of that. GFF, yes. The first 4 countries of GFF priority are Kenya, Tanzania, Ethiopia, and DRC Congo. So if you are in any of those countries, please wake up to this thing happening. The meeting was in Tanzania, I believe, a week ago. Kenya, it was there, and the faith-based groups, I believe, were invited. The question that's here is, and this is a rhetorical question, when we arrange this thing with the country, with the ministries of health, and with the partners who are on the ground, to what extent do your government view you as real partners, so that we cannot go there alone without you? You know, in the African culture, if you are going to pay dowry, there are some friends of yours who are so close you must go with them. You cannot go alone. How come when our Ministers of Health are discussing funding, you are out? When they're discussing service, you are in. This means that there is something very, very wrong in the relationship. We are not real partners, and we have to work on that for us to be able to move forward. With the MOUs, we are working now very, very closely with ministries of health and ministries of justice in turning this around. MOUs were things that were conveniently done by the Ministry of Health without involvement of the legal aspects of it. So they are non-binding. And we are saying that if you're going to go into a proper PPP, where your monies change, staff change, and so on, it has to be legally binding. And this is now going to be changing all over. If you're in Kenya, you will see that. If you're in Uganda, we're doing the same thing. Unfortunately, we're getting the biggest resistance from the faith-based groups. Because they're the ones who are saying we already have an argument that we've been together for the last 50 years. And this acceptance that what you have, yes, it was good when there was nothing. But for where you want to go, that journey takes more than an MOU. If you accept that these documents are not as thorough as you want them to be, then in Uganda, in Kenya, in all these countries, we are able to work together with you to move this agenda forward. I do not know if I will answer anything more. I appreciate your comment from Zimbabwe on the management boards. My bishop is here. He knows that this is something that must concern all of us, that they should not be running these things efficiently must not be seen to be antichrist. And it's something that we have to get right. Because when they run well, then you give the best image of the church and the institutions that we represent. I do not think I can answer all of them, but I will be available through this session to lunchtime for any further discussion. But the organizers also have my contact from the different countries. I will be most happy to help you link with our colleagues in your own countries and for us to be able to move forward together. The government can't do it alone, you can't do it on your own, the donors can't do it on their own. But we have to work together to make UAC a reality. Appreciate it.
Big hands for Professor. Thank you very much for gracing us with your time and this presentation. I will receive these resources. They'll be available so that those who want to see them. And I'm sure we can get more from the World Bank. Professor has been a very passionate advocate for public-private partnerships. I can attest to that. He has really helped those of us in this country to drive that broader partnership agenda. I now want to hand over the session to our next